The obturator nerve arises from L2 to L4 and travels through the psoas major muscle belly before descending into the pelvis. Proximal to the obturator membrane, the nerve lies within the abdominal and pelvic cavity and is therefore not accessible to us via perineural injection therapy there. It exits the pelvis via the obturator canal, which is a small opening within the obturator membrane that spans the obturator foramen. Around this point, either within the canal or just beyond it. The nerve divides into anterior and posterior branches. Note that it comes out under the pubic bone, which is quite different to the femoral branches that are superficial to the pubic bone, and therefore much more accessible. As it emerges, it is just inferior and lateral to the superior pubic ramus into the proximal medial thigh. It then enters the adductor compartment. This branching pattern is important, as it determines how and where we approach treatment. The posterior branch passes more deeply to supply the deeper adductor muscles and contributes to both hip and knee joint innervation. The anterior branch lies more superficially, although it remains covered by adductor longus and only becomes cutaneous distally. It primarily supplies the superficial adductors and is the more accessible branch clinically. Clinically, obturator nerve involvement presents as medial thigh pain, deep groin discomfort, pain with resisted adduction, contribution to hip joint pain, and occasionally referral toward the medial knee. Common sites of irritation include at the nerve root, within psoas proximally, at the obturator canal, and between the adductor muscles distally. From a surface anatomy perspective, target the proximal medial thigh, just inferior to the pubic ramus. Palpate along the adductor longus region to assess if this is the correct nerve. And this may reproduce a deep, aching discomfort. This is a deeper structure than the anterior or lateral femoral cutaneous nerves and requires careful needle control and anatomical awareness. In treatment, identify the point of maximal tenderness. This is typically deeper than superficial fascial nerves and often requires a more medial approach than expected. To find the targeted injection point, find the small recess immediately lateral to the adductor longus insertion, around 2 cm lateral and distal to the pubic ramus. Insert the needle to a depth of approximately 25 mm, using a slightly superior and medial trajectory. After aspirating, inject a volume of around 5 milliliters. You should feel an unimpeded flow from the needle to confirm that you are through the adductor longus and not yet into the adductor brevis muscle. To directly target the nerve more distally in the thigh requires ultrasound-guided hydrodissection, as the nerve lies between the adductor longus, brevis, and magnus layers, the Alabama plane. But this is a skill that requires a great deal of guidance and practice to master.